Type B dissection in Asia, burden of disease and treatment. Would like to invite Professor Stephen Cheng, please.
Thank you very much, Song. So this is an interesting subject, mainly because I was often asked when I go to overseas meetings, what is the exact situation of acute type B dissection in Asia? And the general question I usually ask is, I don't know, because it's very difficult to gather national information from different countries as to what was the current situation and what they do. So there was a meeting in London actually for dissections, and at that meeting I did some research, and I want to share with you what exactly, as I thought, was the current situation in Asia, and you can correct me if I'm wrong, because Asia is really a very large continent, and of course we have this life-threatening situation going on. I believe each country is different in terms of their population, their healthcare system, the culture, whether they're receptive to treatment, the economy, whether you have money for endografts, the industry presence, specialized training, whether they're cardiac surgeons, cardiologists, or vascular surgeons, availability of good imaging, both inside and outside operating theaters. And finally, because it's a large continent, the mode of transportation to specialist centers also matter. This is a study of global accessibility to acute cardiac center care, and you can see that the red, which is the largely the accessible cardiac surgery centers are mostly in the so-called developed countries, whereas in Asia it's generally not that well accessible. We all know that TIVA is the established treatment for type B dissections, and up to 60% of these patients develop aneurysms, and then we should treat them, especially for complicated patients. The question is, what is the risk of doing it, and who to treat, and when to treat this? One of my associates actually early on did a worldwide literature search on 90 publications on the results of TIVA for acute and chronic type B dissections, and also for if you do it acutely and if you do it on acute and chronically, the overall hospital mortality was actually higher if you do this on an acute type B dissection. That is worldwide literature. So should we do it? I try to summarize this in the different regions. For North Asia, which literally means Korea and Japan, China, which is of course the major treatment centers for dissections, Southeast Asia, which is us, Thailand, Singapore, Hong Kong, Vietnam, and maybe some of the developing area, which I include India, for example. I don't know very much about India, but I talk to various industry people, and they say that 60 to 70% of type B dissections is now treated with endovascular means, but most cardiac surgeons are not trained in doing endovascular procedures. So it comes down to the IR and the vascular surgeons. I think they do roughly about 1,000 per year in terms of TIVA distributed in these various centers. Korea is also very difficult to get information out of. I believe they are mostly done by interventional radiologists. So if I speak to our Korean surgeons, they don't have control of TIVAs. So I think from that database of 20,000 patients, about 690, 700 patients do go for TIVA. And the number is increasing in Korea. You can see that the blue is the use of TIVA, and the mortality is quite acceptable in terms of 5-10 years. The blue is TIVA. It's very comparable with type B surgical repair, and for medical management, it's actually superior. So I think the message is there. Japan's easier because the National Society publish data every year. And the interesting thing is you see Japan, actually the patients average are much older. So 70 years old for men and 76 years old for women for acute type B dissections in Japan. And they have very good hospital mortality rates. It's only 4.5%. If you look at the national data, when 92% of the patients used to be managed medically, that is up to database of 2015. So I do believe in Japan, they are more conservative, and they only operate mostly on the complicated patients. So this is type A. in Japan, mortality you see, and this is type B dissection. You can see that the operating mortality for type B is actually higher than type A. So I do believe that they may be more conservative in treating their patients, although again from the national Japanese data, the use of TIVR is increasing, that is the gray bar, is increasing slowly, and they mostly do it for chronic rather than for acute situations. The increase is much more dramatic for chronic dissection. Sorry. So, and for type B dissection as well, you can see that for emergency and urgent situations, then a significant number, 50 and 39% is done endovascular. But then most of these were done without branch reconstruction. Again, that is the national database. 76% were done either covering the left subclavian or doing it lower down in zone 3. So I do believe Japanese doctors may be more conservative in this regard. And although the operating mortality for TIVR in the blue chart is definitely better than the open repair for type B dissections. So in conclusion, I believe in Japan, the incidence is probably higher than the West, but they are older patients, mostly male patients compared to female. They are more conservative, and they seem to be more treating complicated cases. And if you do complicated cases, obviously the operating mortality would be higher. Now, China, I know there are esteemed Chinese surgeons here, so I may be wrong, but based on this, from what I read, from Professor Xu Chang also publishes national reports from China. I know that they have chest pain centers all across China. So if you have chest pain, you actually go to a dedicated chest pain center. So the pickup rate is pretty high. I think in Hong Kong, we are moving into that direction. But interestingly, in China, I believe the age of patient with type B dissection is much younger. So in two different publications, the average age is 52 and 54. So that is at least 20 years younger. So why? So this is the national data looking at dissections, and I believe that the main reason for patients, a survey of 3,000 hospitals, most of these patients have hypertension. So younger patients, again, 58 years old, hypertension is more prevalent, and that is more the reason why they have this problem in China. Massive numbers, in 2023 alone, 30,000 TIVRs was done in China, largely by very, very experienced centers, mainly distributed in these red and yellow areas. So it's not nationwide, it's very highly concentrated in very special centers. And in fact, this is again, Professor Xu's data is not here, unfortunately. In 2023, 5% of the hospitals in China perform almost 50% of the TIVRs in the whole territory. So it's always coming to very specialized centers. Now, they are not doing it randomly. They have very good guidelines in China, publishing compared to Western guidelines as to who you should treat and who are the high-risk patients. Likewise, these are standard criteria for high-risk patients in China, who will then receive TIVR. The interesting that we go for high risk, and yes, if they're suitable, they always almost invariably go along this path to receive TIVR. Unless they're not suitable, then they go for medical surveillance. The results in TIVR in China is also good compared to large-scale studies in the West, and compared to China, you can see that actually the mortality is actually lower in all respects. The long-term mortality is lower. The hospital mortality is lower. If you believe the published reports, they are very comparable in red, which is China, to those in blue. So I believe that in acute type B dissection in China, average age 10 years younger, and the arguments when I talk to Chinese surgeons, why do you want to do an early TIVR, is that because the results are better, because the patients are younger, and surveillance is sometimes difficult because they come from all sorts, all over the country to your center, and there may be also a hospital incentive to try to do more, right? At the expense of maybe some of these procedures are not entirely successful technically. So again, this is one of the meta-analysis. Sorry, keep pressing the wrong button. on TIVA, and you can see that in uncomplicated type B dissections, in 25 publications, systematic review in China, the type 1 endolytic rate is actually 8.7%. So that depends on how you define the proximal landing zone. And likewise, when I said most people, this is interesting data showing discharge statistics. So the yellow, the orange is the DAMA, meaning you discharge against medical advice, meaning you go to some other hospitals to seek treatment. It's actually higher if you don't do that many a year. So in very experienced centers, people don't leave. But if you are going to a not very experienced center, the patient will leave. So to keep the patient in the hospital, you probably need to do that. This is from one of our associate hospitals in Shenzhen, and somehow they audit what you do. So you have to, each month you have to report the number of operations for your discharged patient and divide it by the total number of discharged patients in the same period. So if that number is low, then you're not doing well. So there's an incentive that you have to do more. So young patients, hypertension management is important. They have good results, lower complication and mortality rates. Most of them are uncomplicated. They're limited insurance, there's shortage of follow-up, there's difficulty for medical management, but generally healthier patients, and you will see very often good results, better mid to long-term results. They are innovative procedures. I don't want to repeat here because it's been repeated by other doctors already. The fenestrations, in situ fenestrations, using balloons and lasers in multiple publications on this C-skirt device combined with fenestration. PMATs, like Dr. Poon-Presit has mentioned, again, it's very well done. In China, they have the Castor device, single branch device, despite that most of the patients in their initial trial is 53% has a tear retrograde all the way up to the left subclavian artery. The results of clinical success is very good. So 98% clinical success on these very difficult patients. Hong Kong, we don't do that many. These are the national numbers, about 200 a year for type B dissection. Not everybody agrees to do it in the acute phase or subacute phase. So these are the average number for type B dissections. In no way we can compare with mainland China. I think for us, the key is try to not do difficult things. So this is the TBE we just did, and you can look at the wire where it go, and you can, before we do anything, you can see this ascending shadow expanding gradually, right? So this is even before the graft was in there, there was already a retrograde type A dissection in this patient, and we hurry the patient to finish the procedure. When do the CT scan, there's a type B dissection. This is the main counter argument against doing a TIVA in patients in type B dissections because you cause harm. So I think for us, we are more conservative. There are funding issues, and there's not sure whether we should preemptively do TIVA in some acute or chronic stages. We can do this. We don't want to expand. We covered this already, doing various branch and fenestrated devices using distal coverage, additional procedures. This is a China fabulous study using distal coverage to increase the distal expansion of the false lumen. Fenestrated graft we reserve for chronic dissections. Occluders, we've shown that we've used some false lumen occluders in the case we put two to close the false lumen. The Chinese interesting occluders also meant to cover the tears or secondary or the primary tears. But by and large, in our experience in Hong Kong, we do believe that if you delay the operation to more than 90 days, then your primary success is less. We have evidence to show you that if you leave it until chronic, when the aneurysm size is more than 5 centimeters, again, the primary success rate is less, and also the re-intervention rate is less. So I completely agree that we probably should go for an earlier TIVA in type B dissection. The key is try not to do it and introduce risk. So summary again, acute dissection in Asia, I think is increasing because it's increasing detection. More TIVA is being done, varying indications, depends on country. Generally, we have good results because the patients are better and younger, and there are a number of endografts that are coming in or being manufactured in China, for example, very innovative, and I do believe that we should do preemptive treatment for high-risk patients. Thank you very much.